screen. So do we now see a title screen?
Yes, we do.
That is great. Then I'll start talking. Thank you very much, Professor Waldman. It's an honor to be here. My name is Peter Ventevogel. I think you can see me on screen, but this is also a picture. I will do the first part of this tripartite presentation, and I will focus mostly on what we know about the effects of COVID-19 on mental health and well-being of people in humanitarian settings, as well as the effects that the COVID pandemic has on the programming in mental health and psychosocial support. We will then move on to Florence Baingana, who will talk about the experiences in other pandemics as well, and then finally to Fahmy, my colleague from WHO, who will present us and walk us through many guidance and practical tools that have been developed by the WHO and by other agencies collaboratively. And then we will lastly move to field experiences, but I will tell you later. Before I start talking about COVID, I think we need to realize that first of all, mental health problems are prevalent anywhere in the world, depending how you measure it, how you define it. We can think something like 13% of the population at any given time, some figures are even higher, suffers from a mental health condition. In humanitarian settings, that figure is considerably higher. So that's the slide that I show you here. These are the latest estimates published last year in the Lancet, showing that in a humanitarian setting, conflict-affected population, around 22% of the population has a clinically relevant mental health condition. That's around 1 in 5. And if you look at the first row, severe disorders, people with psychosis, mania, or severe forms of depression or anxiety, people who really need clinical attention, that is 5%. That's 1 in 20. If you project that on the numbers of people in humanitarian settings, we get to very high figures. However, on top of that now, we have the COVID situation and the COVID response that also affects the well-being and mental health of the people in the humanitarian settings. So that's what we will focus on. Now, this slide puts together a few of the reasons why we can expect that within humanitarian settings, the mental health of people is affected, and to some extent even disproportionately. I distinguish two risks, two types of risks. First, the risks that are directly related to COVID-19, and secondly, the risks that are related to changes in the context in which people live. Now, this first group, obviously, some people, particularly when they are in hospital settings, are at increased risks. Hospitals are not necessarily the safest place these days if infection control is not well managed. That is, of course, true for people who live in psychiatric institutions or people who are admitted in a ward in a hospital with a mental health condition. But it may also be a bit more related to the kind of mental health problem that people have, which may affect their ability to engage with risks, to understand the risks and to adapt their behavior. So you can think about people who have currently a psychotic or a manic episode. People with intellectual disabilities, developmental disorders may find it difficult to engage with this new risk environment. And lastly, some people are at higher risk because they have a mental health disorder that is connected to medical concerns, particularly people who use antipsychotic medication and may have additional issues related to weight increase or cardiovascular problems, which are risk factors. So that's the first group. The second group, and I think that's actually perhaps more important in terms of numbers, are the risks that are related to how their social environment changes. People with mental health conditions, as for everyone, the social support systems are extremely important for their well-being, perhaps even more so if you have a mental health condition. But those social support systems become dysfunctional or overburdened. Caretakers may get sick, may die, may get quarantined. So this causes quite a lot of additional stress. The whole movement restrictions, we see that all over the board. We see now in many countries after a few weeks of lockdown, people really find it tough. Well, these issues are often increased even if you have a mental health condition and you're already not feeling very okay. Then, of course, there are risks related to violence, increased gender violence, gender-based violence, protection risks for children with intellectual developmental disorders, etc. Then there is, of course, a risk that people can't access their helpers, their regular helpers anymore. And finally, but this may be the big thing, people lose their livelihoods and lose opportunities to have a decent life. That's all over the board in humanitarian settings. The major worry now, how will it go on with us? How will our life look? It's a matter of life and death often. This causes a huge additional stress. Now, having said this, what does that mean for how we do our work in mental health and psychosocial support? I leave this slide actually in the because of time, because I mentioned most of the groups already implicitly while I was talking, with the exception perhaps of people with cognitive disorders or disabilities, people with dementia, who are really at high risk for several reasons. What I want to do now, and that's actually the major part of what I want to say, is how do the COVID scenarios, the COVID situation, how does that affect the way we do our mental health and psychosocial support programming? And I've been co-chairing an ad hoc group of the IESC reference group for mental health and psychosocial support. The reference group is co-chaired by Fahmy. He's doing incredible good things to provide support and guidance to the people working in the field. One of the activities is a subgroup on considerations around continuation of comprehensive care in COVID settings and comprehensive MHPSS care, that is. So I have 2 slides. Yes, how far am I?
You're 8 minutes in.
Okay, that's horrible. That's always the case. Then I will show you the slide, but not go into the details. We can do that in the discussion. I think you may have gone through it to some extent. So we use the WHO categories classifications of COVID situations. And then with this group of 35 people from NGOs, MSF, all the major NGOs and UN agencies, we defined what we think are the effects on the MHPSS programming. And then the next slide is how MHPSS programs need to be adapted in the different scenarios, from the beginning where there are actually no or very few cases to scenarios that are a bit more advanced, where you really have to make sure you can't help everyone anymore. You have to choose to prioritize the people with more severe conditions, and you have to adapt your services towards teleworking. That's the second adaptation. And the third one is that we probably will have to, or actually that's happening, we have to rely much more on community-based staff, including volunteers. I have much more to talk about, but I will not do that because Dr. Waldman told me he will stop me if I talk too long, because we want to have an open discussion with all of you. The document that this comes from is currently being reviewed, and we hope to get it out somewhere next week. If you would be interested in it, write me directly so I can already perhaps share an advanced draft. Without that, I will stop talking and move on to my good colleague Florence Baingana, who I think many of you know. She's currently the WHO Regional Advisor for Mental Health and Substance Use. Florence, can you hear me?
Yes, I can hear you
And we
very
can
well.
hear you
Thank you,
too, so
Peter.
go ahead.
Thank you. So you'll move the slides for me, will you?
Yes, I will.
Okay, thank you. So you can go to the next one. Thank you so much to the organizers for including me in this. Since I have only 6 to 7 minutes, I will jump right in. I'm sure we are all familiar with the West Africa Ebola epidemic, as well as the COVID-19. However, there are a few differences between the West Africa Ebola epidemic and the COVID-19. One is the modes of spread. With Ebola, it was more of direct contact with body fluids. So one had to have touched a patient or got in touch with the body fluids, and it was very, very transmissible in that way. It also has a very high death rate, while the COVID-19, which has a much lower death rate, but because of it being very highly transmissible, therefore we have very rapid and very widespread spread. If you look on the right-hand side of the screen, this one is taken from The Guardian, but it just shows you how rapidly it has moved across the world. And while we don't have so much here in sub-Saharan Africa, but everybody seems to predict it will come here soon. Hello, you can still hear me?
Absolutely, yes.
Okay, and the Ebola was localized. The West African one was mainly in West Africa, and then we have the one that's in the DRC that has come up again. So it hasn't been like a global pandemic. The similarities are quarantines and lockdowns and social isolation. We have stigma and we have fear. If we could go into the next slide, please. The next slide, yes. So we have the socio-ecological model that we came up with during the Ebola, and it actually applies to COVID as well. We have individuals, the individuals who get the disorder, some of them have self-stigma, but they also face a lot of stigma from the communities. We find that this too is also, the COVID is also affected by poverty and by fear. There's a lot of fear surrounding it in the individual. We have the interpersonal being stigma against the individuals within families. We have cases where families suspect their own family members and they're reporting them, neighbors reporting their people in their neighborhoods, and there's a lot of fear as well. Institutional, we see the very same things that we saw within the Ebola epidemic, overwhelmed institutions, healthcare systems overwhelmed, and it was actually quite surprising to see that even institutions in the north have been overwhelmed, in the global north, overwhelmed by the extent of the pandemic. There's fear, there's poor remuneration of healthcare workers, inadequate supplies, and this is globally, it is not just in the developing world. And then we have, of course, the structural, poor and weak governance systems, mistrust of governments. We are seeing quite a bit of this everywhere. So this is no longer a phenomenon which is found only in low-income countries or only in Africa. We have beliefs and cultural norms impacting how people are going to behave, how they're going to respond to what is decided or not. And then we also have stigma, fear, and poverty. I think what is special about the humanitarian context as well, which I feel I should mention, is that 80% of refugees are in low-income countries, and 100% of internally displaced persons are actually in low-income countries. So this is something to think about, because we know what most refugee camps look like. When refugees are being housed in camps, they are very crowded, there's poor sanitation for some of them, and this compounds the hopelessness that they may be feeling in controlling the environments and having an ability to have some control over their own well-being, which may be something which goes beyond what the rest of us feel who do not live like refugees or IDPs. May I have the next slide, please? Peter? Thank you. So what potential lessons can we learn from the EVD? I think one is the anti-stigma interventions. During EVD, when people were going home, we had to develop interventions to help the reintegration of the survivors of EVD. We have had to do the same thing now, where we have to prepare the communities and the families, as well as general anti-stigma programming for the general population. The next one is how to reach as many people as possible with tailored interventions, because it's not going to be one intervention that is effective for everybody. We need one for those who may be in quarantine. We need for those who may be in the treatment centers. We had guidelines for the ET used during Ebola, but right now we are developing clinical guidelines for people who are being treated for the COVID-19. We also have to have specific interventions for healthcare workers, and these are very important because healthcare workers actually being affected much more so, I think, in this pandemic than they were in the EVD. So I cannot overemphasize the importance of mental health psychosocial support for healthcare workers. It can't be overemphasized because of just the numbers that have been impacted. And then we have to think as well about post-Ebola interventions integrated into care packages. So we don't want them as standalone interventions, but we would want them integrated into education, into social welfare, into health, into community development programming. And this is not something that we can do right now, but we need to begin planning for what will happen post-COVID-19. How are we going to ensure that those who may need support are going to get it? And so, of course, I keep emphasizing integration, 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 because we don't want standalone mental health psychosocial support programs. Thank you very much.
Thank you very much, Florence. That is always such a pleasure to hear you talking and hear your experiences. I'm trying to get to the next slide, which I failed to do now, so I will do it in this way. Let's move to our colleague Fahmy Hanna, who is with WHO. Fahmy, can you hear me? If so, go ahead.
Yes, I can. Thank you, Peter, and thank you, Ron. If we can move to the next slide, please, Peter. This is an emergency which is happening in every country in the world. Coordination challenges are unprecedented. Coordination needs to happen in this emergency at multiple levels. So WHO is co-chairing together with the International Federation for Red Cross and Red Crescent Societies, ISC, MHPSS reference group, which is a unique collaboration between United Nations agencies, international NGOs, Red Cross and Red Crescent societies, mental health and psychosocial support focal points. And it is unique because it's not only the health sector, it is the colleagues who are members of this reference group work on sectors such as education, such as nutrition, such as protection, and among many others, because MHPSS is cross-cutting area, and this group has played a key role in coordinating the response. The group has been meeting on weekly basis since this emergency was starting as an outbreak in Wuhan, and still continue to do so on weekly basis to coordinate the response. But also the group started to arrange for monthly call for country level MHPSS technical working group leads in different emergencies. Yesterday was one of these calls, and it was attended by chairs of this group from 18 humanitarian emergencies. WHO also, through the collaboration with the emergency program, collaborate with the different pillars of the incident management system, because within public health emergency response, MHPSS is also cross-cutting. So it's cross-cutting across sector and also cross-cutting within health itself as a sector. So MHPSS is relevant for risk communication and community engagement pillar of the response. It's also relevant for clinical guidance pillar. It's also relevant for logistics support through staff care and staff well-being. So it's a cross-cutting within public health and emergency response, and also cross-cutting within WHO different areas of work. So in all guidance developed by colleagues in different departments such as maternal and child care, such as other infectious disease, such as HIV. We need to make sure that MHPSS is integrated, and WHO, through its wide network of regional offices, country offices, we need to make sure that all material developed in collaboration with our colleagues in countries are translated and adapted to this context, in each specific context in every country. Next, please, Peter. This document we see here it's really quite an influential document in MHPSS response in this emergency. We developed this through interagency consensus process that started very early in the response. This was developed back in February. And what we developed, thinking about the emergency in China and thinking about humanitarian response in places such as Bangladesh, Syria, South Sudan, and others, was found relevant also by high-income countries. So if you go to the ISC website, you will find the logo of the ministries of many high-income countries, including within Europe, who found this document relevant and translated, adapted, endorsed, and used in their country. I think this is a document which is available in more than 30+ languages. It focuses on programmatic guidance, putting some recommended activities that program managers can use for MHPSS in this situation. And there are a number of derivative products from this document. One of the key ones is guidance on how to integrate MHPSS into country response plan and humanitarian response plan. And since this is a document endorsed by the ISC, the highest level humanitarian forum, so the recommendations included in this HRP guidance, which is based on this document, our recommendations also are in line with the highest level humanitarian forum. Also, in addition to sets of standardized PowerPoint slide for orienting cluster from different clusters and emergencies. Next, please, Peter. This document, My Hero Is You, this children's storybook, is released on the 9th of April. This is a little less than 2 weeks ago. So far, there are online now 25 translations of this document, and there are ongoing in the pipeline 80 other languages translation. A document released less than 2 weeks ago, having 106 translations in different languages. So what's really unique about this document that created all this demand from the field once it was released? First, what's unique about this document is that we asked the service users, we asked children and parents before we develop it. Through the network of the reference group, all agencies collaborated to disseminate a survey that was filled by 1,700 children and parents from 100 countries. We also tested it through storytelling in different humanitarian settings, and then collected the feedback and created a story for children. I think another reason for this high demand is the fact that it's not only the physical health need which concerns the parents and children, it's also mental health needs. This document, through its wide dissemination, tell us how countries really require document like this, and how it's important, relevant for basically for parents and families. Most of the translation I mentioned are actually done by volunteer groups in countries. And third, this children's story book was launched with quotes from agency leads. So it was launched by the UNHCR High Commissioner, by WHO Director General, UNESCO Director General, and UNICEF Executive Director. A children's storybook turned into a policy influence tool to advocate for children's mental health all around the world. And the media uptake for this was great. So it's great to see advocacy all around the world through a children's storybook. It shows how effective and how there is a need for tools like this. Next, please, Peter. In an emergency happening in all countries of the world, communication and risk communication is key. So this is guidance developed by WHO specifically for this purpose as part of risk communication package for COVID-19. Next, please. And based on this guidance, wide range of infographics, social media cards was disseminated, and also the Healthy at Home WHO campaign. These materials are available online on the WHO website and has been disseminated extensively in different languages for sending stress coping messages on social media in different platforms. Next, please, Peter. And this is a call for innovations how practitioners are adapting their services. And the first round of this call has been published already on the Mental Health Innovation Network, and this will continue. Next, please, Peter. There are many products in the pipeline, and I thank Peter for his leadership on the group on continuation of clinical care. There are also other products in the pipeline, including guidance on tele-MHPSS programming. There is also guidance coming in the pipeline on substance use and addictive behavior, including online gaming, for example, during the times of COVID. And there is an orientation manual for responders, not only health responders, but for responders from different sectors on integrating psychosocial aspects into COVID response. Next, please.
Fahmy, could you finish up? We'd like to move to the field reports.
Sure, thank you. And finally, guidance on the clinical and mental health and neurological aspects of COVID-19 itself, because there are symptoms such as delirium and anxiety, insomnia associated with COVID, and we do this in collaboration with the team from the response working on clinical care, and this is again one of the products in the pipeline. And WHO is working on an internal framework for its offices in the recovery phase to make sure that MHPSS integrated into all country offices response as part of the recovery phase from COVID. This is also in drafting process. Thank you.
Great, thank you very much, Fahmy. These were the presentations from more or less HQ-based people. We now move on to brief snapshots from country operations. So I would first like to listen to Mahmouda, my colleague in UNHCR Cox's Bazar in Bangladesh, whom I know for 6 years already. She's been working in the Rohingya context for, I think, 7 years with NGOs, with UNHCR. She's a psychologist from Bangladesh who speaks the Rohingya language and engages very closely with them, was with them before the big emergency happened, before the monsoons and before this COVID. So she really knows the situation very well. We asked her to make a video, and we're going to try if it works. But she will also be online to answer any questions. Let's see if this works. Can someone tell me if you can hear Mahmouda?
I am Mahmouda, a psychologist from Bangladesh. I work for a team, mental health and psychosocial.
Can you hear her?
Yes, Peter, go ahead, please.
Support for UNHCR Cox's Bazar. The area of Bangladesh hosts around 1 million Rohingya refugees. Most of them are hosted in Kutupalong mega camp. This is very densely populated area, over 500,000 of people. UNHCR mental health and psychosocial support team is working in an integrated way with protection and health partners for delivering mental health and psychosocial support services. These services are needed for refugees because they are suffering for different types of stress, insecurity, hopelessness, frustration, and anxiety and worry. For this reason, we are trying to support them in this pandemic situation. Till now, there are no COVID in camps, but we all worry for this disaster if it would happen. Every year, we take preparation for this monsoon period. This year, we are taking preparation for this COVID-19. We are trying to develop some alternative working modalities because we are not allowed to directly go to the field, and most of the staffs are working from home. All are in same position. So we have developed this module for the psychologists. They have received a training, and psychologists disseminated this training for the community psychosocial volunteers, community para-counselors, and community health workers. Now they are trying to reach inside the camp by maintaining social distance and also other hygienic precaution. They are disseminating awareness messages from mental health and psychosocial support aspects. We have developed few alternative audio and video recordings. These are really helpful for the volunteers and for the refugee community people. We have also developed and printed some key messages. These key messages is easy to understand by seeing with the pictures. People can easily understand these things. And we have developed other working modalities like remote online supervision and coordination in this time period. And we have working with the working group because UNHCR is one of the leading organization for this MHPSS working group. This working group also working for the staff self-care. We have arranged 2 webinars for this staff. So national and international staffs are benefited from this self-care session. And also we are trying to do these things, all the alternative ways, so that people can get more information in this situation. We are happy to support them. Thank you.
Great, thank you, Mahmouda. I think you're also on the line. I will see if I can unmute you. No, we will do that later, but I see you online, so that's great. If anyone has questions to Mahmouda, please put them in the chat box or make sure you raise your hand. I think the situation in Cox's Bazar is really, let's say it's okay now, but you can just imagine, anyone who has seen the setting there, if COVID starts spreading there, it will be really a disaster. Now, let's now move on to Nigeria, where in the northeast of Nigeria, in Maiduguri, there is a colleague of us, Deborah Magdalena, who is an expatriate psychologist who leads the mental health and psychosocial support working group there. And I would like to ask her to share with us just in 3 minutes her experiences with COVID and MHPSS. Deborah, are you there?
Yes, Peter, can you hear my voice?
Yes, you need to speak a little bit more in the microphone if you can.
Okay, sure.
Yeah,
is it okay?
this is good.
Yes.
Yeah.
All right. Okay. Thank you very much, Peters, and greetings to everyone from Maiduguri. I'm Deborah, the Mental Health and Psychosocial Support Working Group Coordinator for the Northeast Nigeria. So the role is actually to support the State Ministry of Health, who is also the chair of the MHPSS Working Group, to strengthen its coordination mechanism to improve the design delivery of the MHPSS intervention in 3 states. It's in Borno, Adamawa, and Yobe. And also to coordinate the activity with partners and other relevant sectors such as the health, protection, child protection, GBV, camp coordination, camp management, and livelihoods. So currently the MHPSS working group in the Northeast Nigeria, we have 49 partners from national NGOs, international NGOs, RCRC movement, UN agency, and the government institutions. I would like to go into the context of the humanitarian crisis in Nigeria. This is really like one of the complex crises. And after 10 years of the conflict, the crisis remain one of the most severe in the world and continue to cause like untold suffering for millions of Nigerians, particularly women and children. So based on the Nigeria Humanitarian Response Plan in 2020, a total of 7.9 million people in need of life-saving aids. The majority of the people in need are in Borno State, which is the epicenter of the crisis, with women and children constitute of 81% of the overall crisis population and 87% of the new displacement. So this is a protection crisis and have major impacts and concern for the overall living standard, physical and psychological well-being, and the capacity for resilience and coping mechanism of their IDPs, returnees, and host communities. There are more than 140 campsites, with the highest number of more than 42,000 individuals living in one camp. And this is the issue in the camp related with the congested increase of fire outbreak because of the weather, also because of the congested area with the shelter. There's a lack of access to the potable water, sanitation, hygiene, food security, limited access to the health facility. There's also multiple disease outbreak and increase of sexual violence and abuse. So the COVID-19 pandemic is adding another layer to the existing crisis that we have to deal with. So we already have a confirmed case last week in Borno State, and the numbers keep increasing up to today. Sorry, I'll try to like really keep up the timing and like talking a bit like really faster. So the MHPSS partners have responding in a specific way due to the limitation. So we have observed the prevention measure and the new regulation. There is already a changing modality to implement the MHPSS activity with smaller number of staff working directly in the IDP camps and host community. So there's a lot of organizations like IOM, IRCRC movement, MDM, MSF, UNICEF, UNHCR, WHO, among others. So they have had several scenarios and plans and activities to be implemented. So the activities such as community awareness is continue with a small number of individuals focusing on the structured information related with the COVID-19 about the hygiene promotion, dealing with misinformation, myth, social stigma, also working with fear, anxiety, confusion, and also the level of understanding and acceptance of the current reality. The remote supervision is ongoing. The structured recreational activity is the one that really affected much because it has been stopped as the safe spaces have been closed. In regard to the mental health and specialized services, is still ongoing with reducing on the face-to-face method, working more on the active cases. So we have like more reducing also on the referrals and new identification of person with mental health condition. The MHPSS partners also working with the health worker on specific activity on psychological first aid to COVID-19 pandemic and staff care. There's an important key psychosocial aspect in related to the MHPSS response in how to increase the self-efficacy of the affected population and restore their confidence to be able to deal with the daily issue. This is with condition that there is social psychological measure determining the response related with the pandemic. There is need to observe the aspect of culture and also community resilience in the midst of pandemic and how it could be restructured without putting further harm to the community. So the last one, the humanitarian actors is amplify the government efforts will support to increase the availability and adaptability of the COVID-19 response services. The MHPSS actor will continue its collaboration with other relevant sectors for a coordinated response and to ensure promoting the well-being of the individuals that we are supporting with this current crisis. Thank you very much, and over to you, Peter.
Thank you. Thank you very much, Deborah. Good to hear all the things that are being done, and wish you good luck and strength. I think I will pass on the baton to Professor Waldman to lead the discussion. Are you ready for that?
Yes, thank you, Peter. We have a number of questions here. I would like to really thank all of you who have spoken this morning for making great contributions to the discussion, and I hope we'll continue for the rest of the time we have available to expand on many of the points you have made. Let me start by asking a question about just the ability to work remotely and to provide mental health services the way we're doing the rest of our work now. Peter, do you want to start maybe by addressing this issue?
I mean, the short answer is, of course, it's not easy, but we have to. There is no other way out. And we are seeing things are happening. We work, for example, with the Teachers College in New York at Columbia University, who have developed interpersonal therapy. And they work with us in different settings to introduce that, which is basically a group therapy that you do in groups. That's the whole essence about it. We are now adapting it and have to adapt it rather quickly to individual formats and to briefer formats that can be delivered by people with more minimal training over the phone. So these are things we are now talking about to do in Tanzania and in Bangladesh. So yes, it is happening, but I do think transforming psychological therapies in online modalities is more than just putting a Skype in between the therapist and the patient. That can be one option, but other options, of course, are to work through, for example, helplines, or to work through mobile phone apps that have been developed, but now these things get are being developed in a much faster pace. I may pass over to Fahmy or to Annie. You're the boss, Ron.
Yeah, well, Fahmy, do you have anything to add to that? And then maybe someone can continue on with I'd like also to ask whether it's possible to devote some specific interventions to gender issues, you know, how to the mental health issues sort themselves out according to gender. We know that women are frequently disadvantaged in situations like this. We've heard a lot about the rise in domestic abuse, for example, and I was wondering if the mental health interventions, one of our participants wonders if the mental health interventions also can be made gender specific.
Ron and Peter, thank you, and thanks for colleagues who asked these important questions. The call we had yesterday for colleagues who lead coordination groups from different emergencies was actually supposed to be an in-person meeting that we have every year, but we shifted this global coordination meeting into a call that we plan to do not only once a year, that we plan now to do on monthly basis. I think tele-MHPSS programming, similar to the opportunities we're getting with coordination, is the opportunity in this emergency. We always were questioning whether it is possible to do supervision for MHPSS interventions online, to deliver counseling and psychotherapy online. But now we have to do it online, and it gives us the ability to reach places that we were not able to reach through physical presence. So I think this emergency really is the opportunity for tele-MHPSS programming. And as I mentioned, in our forthcoming guidance, there are specific guidance on how to adapt different MHPSS interventions for remote or tele programming. The same applies to gender. MHPSS aspects of gender-based violence is key, and MHPSS is one of the pillars of any GBV response. And again, on the forthcoming guidance for orientation of responders, as well guidance for service providers, there will be specific recommendations on this important aspects, as I think in all MHPSS advice. Thank you.
Thanks, Fahmy. Florence, I wonder if I can ask you. A lot of the countries, and the ones we're dealing with this morning, have relatively weak mental health services to begin with. Now we're dealing with a problem which, as you mentioned, is different from Ebola in that, as of now, at least it seems to have no end, or at least it will be continuing for quite some time. How can those weaker health systems be maintained in terms of being able to deliver mental health services over the long time? Is there the opportunity to continue to strengthen them as this crisis moves on? I was wondering, hearing Fahmy just now, is it possible to work with the deliverers of these services to increase their ability to provide service? Is it possible to have a greater exchange from you guys, for example, from the UN agencies to provide greater support? Florence?
Mm-hmm. Yes. Yeah, another good question. This also builds on to the previous question about how to provide support, maybe tele-support or virtual support in the context of COVID. One way that I think helps to strengthen the healthcare system, but which is probably a practice, and I'm sure those in the field, that two people who are speaking from the field will confirm this, is to build the capacity of the refugees themselves, or the people who are affected, internally displaced persons themselves, to be able to provide some of the interventions, so that if you have a situation like we have now where external workers cannot go in, it is still possible for some of the services to continue, because the IDPs or the refugees themselves had some kind of profession, some education before they became what they are. So it is possible to draw on the existing resources within these communities to have services delivered. But if we go to building, strengthening mental health systems, even before the COVID, mental health had been prioritized. As we all know, it was included within the SDGs, but carrying that further, as WHO, mental health has been prioritized and is included within universal health coverage and in our operational planning for the next 2 years and the next 5 years, the global program of work. So mental health has been prioritized, and we do plan to strengthen mental health systems within health system strengthening. So hopefully we shall build back stronger mental health systems following on from the COVID. Over to you.
Thank you, Florence. Let me ask then just about the stress that this situation puts not only on the populations, but on health workers and others that are seeking to provide assistance. What is some guidance that you might be able to give to those people who are the helpers and who are under incredible stress themselves? Peter?
Yeah, I think Fahmy can say a little bit more about the product that is coming from the IS reference group, but in general, of course, we all face it. So of course, it is important to take good care of yourself and of others. And I think the main tool to do that is have an openness and a platform where people can talk about how they're doing and how they're feeling, which is not always in an emergency the natural thing to do. People are in an emergency mode, are working, just ignoring whatever emotional issues they have. And I think the most important thing is to provide a place. And I see here a space, a social space to do that. And that can be online in your team. And I see here a great responsibility for team leaders to open that and that discussion, whether people are able to cope, and maybe sometimes people need to take off a little bit, because initially you see that people work day and night, and you can do that perhaps for 2 weeks, but after that you will have to go down a little bit. So, and to normalize, I hope also that the crisis somehow helps to normalize mental health issues, because we're all in it. And actually, I hear a lot of people talking about their mental health these days more than before. So I hope we can just realize that this is just part of being stressed out.
Ron, thank you for this question. And one of the messages is that in stressful times, in difficult times, it's normal to experience stress. There are lots that you can do about coping, encouraging positive coping methods. First, do not make, as health worker or as responder, COVID as the center of your life or the only focus of your life. Take breaks. Do not make your breaks from your health work through watching the news only about COVID. Take some time off from COVID and do something different. Do positive coping. Keep a healthy lifestyle. Try to keep as possible a normal daily routine. Good sleep, healthy diet, good exercise, and avoid negative coping mechanisms, including alcohol or other negative coping mechanisms. And remember, as a health worker, this is a situation that would take time to be resolved. You need to take rest. This is a marathon, not a sprint. So give yourself time off from COVID, and remember, there should be also resources available for every health worker to access mental health and psychosocial support for themselves without stigma, in privacy and in confidentiality. And as Peter mentioned, we are in the process of releasing specific orientation manuals for responders. Thank you.
Thank you, Fahmy. You mentioned stigma. Mahmouda, are you on the line? Can you hear?
She needs to be unmuted. I'm not sure she can do that herself.
I don't know how to do that. Okay, well, I wanted to ask the...
Yeah.
Hello?
Yes, I'm hearing you.
Great. Hi, Mahmoud. I wanted to ask you, Fahmy just mentioned the the idea of stigma, and we've certainly seen a lot of stigmatization of different groups and of different populations really pitting themselves against each other. I was wondering, in the refugee situation, what can we do to make sure that the host community perceptions of refugees are not exaggerated in a negative way?
Actually, thank you. This is a very good question, and also this is one of the burning issues from our side as well, because as UNHCR, we are trying to protect them, and also sometimes this confusion arises in different situation. But what we try to do, actually, we are also trying the same messages to disseminate for the host communities. This is one thing, and also the same messages for the refugees, because we have few options. Like as UNHCR, we are obliged to provide some sort of support for the host as well, but we have limited resources. But for the refugees, we are trying to disseminate these messages, because most of the staffs, we are from host. So we are providing support, and all the organizations who are supporting them, most of them are from the Bangladeshi nationals. So this is another part, and we are communicating with them in different ways and trying to develop these things. And in every session in awareness, if they raises any issues, we try to discuss. And also apart these things, we are trying develop the module, like how host community and refugees, just they can be benefited the same way, so that they can also live together. Mostly we have very less tension in this part, but sometimes, like if any incident happens, then like they would like to know and they feel insecure. But more or less they are getting support from other organizations, so host community are not too much aggressive or negative. And also for the refugees, sometimes they feel tension, but they are safe and secure, because all time we are trying to disseminate these messages, and also we are providing as much as we can from our side, and also government is very much supporting, so they feel like they are secure here. These are the part. But for stigma, for our mental health part, we have especially this part, like we are doing the awareness session on reducing this stigma through the community engagement. So community psychosocial volunteers and community para counselors, they are going in the field and they are just discussing these things, because they are bridging with the organization and also the refugee community. So we are working with the community champions, religious leaders, traditional healers, and also with the community volunteers. Just they are disseminating these types of positive messages, so that they can feel free and secure, and they can come and they can understand the scenario, like host community people are not like too much harming for them, and also like they can still here in safe, because we are trying to protect them like this.
Great, thank you so much. That's really very informative. Peter, we only have a few minutes left, and I just wanted to ask if you, maybe in a minute or two, I think it's impossible actually, could you try to summarize some of the major points that we would like to have delivered today?
Well, I think for me, the one major issue, of course, is that mental health is important in the response to the pandemic, both in terms of the population of concern as well as the helpers. I think that became abundantly clear. And I think that we need to think creatively and out of the box to develop new delivery methods. And I think there are at least three areas that we need to focus on. One is to really move on with task sharing approaches, which we are doing in global mental health. We have a lot of task sharing approaches, but I think we need to accelerate that, equip people who are in the communities, because even in a lockdown is never total. People are still having neighbors and people are still going out to get water and food. So I think we need to strengthen the task sharing approaches within the communities. That is one. The second one, I think, is to accelerate the work around online delivery of psychotherapies. When we have to do that, and I think, well, we have to look at scientific integrity, etc., but we just have no choice. We have to. And the third one would be to continue to provide care for those who are the most vulnerable. So those are people with severe mental disorders, people with intellectual developmental disabilities. I mean, the risks are really huge. If we don't protect them and include them, they will really suffer the worst. So those are the three things, my 3 points, but perhaps the colleagues have other issues.
They may have other issues, but I'm afraid we've reached the end of our time. So we might have to do this again. Thank you so much to everyone who presented. It's really been such an informative session. I wonder if, Paul, I think you're on the line. Do you have any information about the next one in this series of Wednesday morning webinars on how the pandemic is affecting the humanitarian situation?
Yes, hi there, Ron, everyone. We will be, the next one will be looking at SBC and community engagement, risk communication, and it will be moderated by Catherine Bertrand. And we will be sending out all of the details shortly. As you're all aware, unfortunately, we're having a lot of issues with Zoom, and so there were issues this morning in terms of the password. We'll do our best to try to address this, but it's all in terms of security. Thank you, Ron, and thanks everyone for this wonderful seminar. It was really, really fantastic.
Thank you, Paul. We look forward to getting the details regarding next week's webinar. Thanks so much to everyone, especially to all those who presented this morning, and thank you all for participating. Thank you very much. Until next week, goodbye, stay safe, stay healthy, stay well. Goodbye.
Goodbye, thank you.